Okay, good afternoon, everyone. My name is Lloyd Morris. I'm with AVS Medical. There have been some significant changes to the Meaningful Use program here lately, and I wanted to share those with you right away. So whether you are scheduled to be in Stage 1 or in Stage 2 in 2015, these changes directly affect you and your plans to attest for meaningful use this year. As many of you know, back in April of this year, the Center for Medicare and Medicaid Services, or CMS, proposed a rule change to meaningful use for 2015. Once that proposed rule change was suggested, it was then subject to a 90-day public comment period. Although that public comment period ended some months ago, CMS did not release the final rule changes until October the 7th, just 1 week ago. Since everyone's attestation period is going to begin no later than October 1st of this year, we wanted to get this information into your hands as quickly as possible. We know that everyone is extremely busy, so rather than doing a live webinar, we've decided to pre-record it so that you can watch this at your convenience. The goal of today's webinar is going to be to review with you the changes that are now official, contrast them with the prior criteria, and finally give you some direction on what you need to be doing right now. Before I move on to the next slide, I do want to stress that time is of the essence. If you're not already working towards meaningful use, you need to begin immediately. So here are a summary of the major changes to the final rule. So on the left we see the old criteria, and on the right we see the new rule changes. And we're going to get into the details of everything, but these are the highlights. So prior to the rule change, the attestation period for 2015 was 12 months. Now, the EHR reporting period for all providers, regardless of stage, will be any 90-day continuous period during calendar year 2015. You can select any 90 days during that time period. In the past, all providers were required to attest to a group of core and menu objectives. Now, for eligible providers, there are 10 objectives, one of which is a public health reporting initiative. If your practice was slated to be in Stage 1 during 2015, you will meet a set of alternative objectives that have been slightly modified for you, but by and large they are the same as for the Stage 2 participants. The other two big changes, and a lot of people were looking forward to these, is that prior to the final rule change, there was a requirement that 5% of all of your patients had to use your patient portal, use your WebView patient portal. That has been changed in the new rule. They've removed the 5% threshold, and now just one patient must actually use it. So that's a big change. The other big change was that under the old criteria, 5% of your patients had to use secure messaging, and that's where they would communicate with the practice through the patient portal. That has also been changed. They've removed the threshold altogether, and the criteria now is that you must just have this enabled. So you must have secure messaging enabled. And it's just a yes or no question. So those are the big changes, but as I say, we're going to get into it in depth here in just a second. Oops, one slide too many. Okay, the other pertinent changes that you need to be aware of is that you must attest using an EHR certified to the 2014 criteria. For Medisoft users, that's Medisoft Clinical V19 or above. It's Lytec MD 2014 or above. Practice Partner version 11 or higher. And for those of you who are using Practice Choice, it's the current version that you are on right now. You must attest no later than February 29th of 2016. Keep in mind your reporting period will end no later than 12/31, but you then have roughly 60 days to actually log on and upload your attestation. This is the other important point I want to make, is that regardless of which 90-day period you select for your attestation period, you cannot actually go through the attestation process until January the 4th of 2016. If a provider does not attest by the 29th of February, you will be subject to a negative payment adjustment starting in calendar year 2017. So this next slide is going to let us take a look at how the next couple slides are going to let us take a look at how the old rule compares to the new rule. I won't go through all of these, but these are the old stage 2 criteria. As you can see, you needed to report on 17 core objectives and then 3 menu objectives for a total of 20 plus your clinical quality measures. Much of this has changed. And here's that same list, but I've color-coded it to show you, to give you a graphical representation of what those changes look like. So the concept here is those things you see in green are the same or are largely the same. The things that are in yellow are still required, but they have been changed, and in some cases changed significantly. And those that are in red are no longer required. So the ones that are no longer required are demographics, vital signs, smoking status, and here's a big one, clinical summaries. A lot of folks did not like the fact they had to print out the clinical summaries. Those are no longer required. Structured lab results, patient list by problem, patient reminders, electronic notes, imaging results, and family history as structured data are no longer required as part of the final rule change. So here are the new objectives for this year. As mentioned, there are a total of 10 that you must meet, and you must meet them all. They have done away with the concept of core and menu, and we just now have this one set. One of these, and it's number 10, is that you need to meet a public health initiative, and you'll also have to report on the CQMs. And I will address each one of these here as we go through it. So let's break down each of those objectives. So objective 1 is now protecting patient health information. This is the same as last year's core objective number 9, which was conducting a security risk analysis. If you've done a security risk analysis or SRA in the past, you don't necessarily have to completely do another one, but you do need to get out the one that you did and update it for this year. Notice that this one is a simple yes/no. There is no minimum percentage. However, I must stress that it's very important that you conduct this security risk audit during your attestation period. In the event that you are ever to be audited, you will need to produce a printed copy of your security risk audit with a date stamp on it during your attestation time frame. You cannot go back after the attestation period is done and do the SRA. You must do it ahead of time. Please make sure you do this one. We have had practices who have literally had to give the money back because they could not produce this. Before I move on, this is a good time to talk about backups. One of the questions, security risk audit, when you go through that security risk audit, one of the questions that you're asked is, do you perform daily backups, and do you remove a copy of the backup out of your practice in the case of a disaster? I want to stress here how important it is that you work with your IT team to make sure that they are making daily backups for you. Your McKesson software does not automatically back up or make a backup, and AVS Medical is not making backups for you. The only exclusion of that is if you are using the cloud-based Practice Choice EMR, and in that case, and it's only in the case of the cloud-based one, McKesson is making a backup for that one. So the second objective is clinical decision support. There are actually 2 measures that are required to meet this objective. The first measure is that you need to implement 5 clinical decision support interventions that are related to 4 or more clinical quality measures. The way that you do this is via health maintenance in your templates and by linking those health maintenance items to your clinical quality measures. If you are not using the AVS consulting services to assist you with meaningful use this year, you can find the steps on how to do this in the configuration and end user training guide starting on page 49. A link to that guide is at the bottom of the blog post where you found this video, so you can download that guide right there. The second measure required to meet this objective is that you have to have drug-drug and drug allergy interaction checking enabled in your EHR during the entire 90-day reporting period. This one, though, is just a simple yes-no, whether you do have it turned on or not. However, our best practice is that we recommend that you take screenshots of this functionality in your EMR at the beginning of your 90-day attestation period, a couple of times during your attestation period, and then once finally at the end. Again, if you were ever audited, you will be asked to produce proof by way of those screenshots that you had this functionality enabled in the software. The only exclusion to this is if you write less than 100 medication orders during your attestation period. That's exclusion is only to measure 2. There is no exclusion for measure 1, only measure 2. The alternate exclusion you see there in the right-hand column, that is for the stage 1 providers. So if you're slated to be in stage 1 this year, you only have to implement one clinical decision support rule. Okay, objective number 3 is computerized physician order entry, or CPOE. There are actually 3 measures that make this one up. And the first measure is that more than 60% of your medication orders are recorded using CPOE. And in our software, a medication order is considered to be an electronic prescription. The second measure required to meet this one is that more than 30% of your lab orders are recorded and created using order entry. The third measure is that more than 30% of your radiology orders must be recorded and entered using the order entry module. Before I talk about the exclusions, let me draw your attention to that phrase, more than. For any of these measures that have a percentage requirement, you must exceed that percentage. So if you were to attest in this example for 60% and you put in 60%, you would fail because it has to be more than that. So we want to shoot for at least 1% above any of these minimum thresholds. Okay, so there are exclusions to each of those measures. So for measure 1, actually the exclusion's the same. So if you do less than 100 prescriptions during your attestation period, you're exempt from measure 1. If you do less than 100 lab orders, you can be exempt from measure 2. And if you do less than 100 radiology orders, you can be exempt from number 3. Okay, and then lastly, if you are in stage 1 this year, then there's only the percentage is only 30%. So the percentages are lower for stage 1 providers. Okay, objective number 4 is electronic prescribing. There's only one measure here, and that is that more than 50% of your permissible prescriptions are transmitted electronically, and that the drug formulary is being queried. There is an exclusion. If you write fewer than 100 permissible prescriptions, you can take the exclusion. A permissible prescription would be a scheduled drug or a narcotic drug. For those of you who are using Practice Choice, you can transmit scheduled drugs, so you would not that would not hold true for you. And then for those providers who are slated to be in stage 1, the measure is the same, but the threshold is a little bit lower. It's 40% instead of 50. One other thing about this one, you have to electronically query the drug formulary. You have that in your software, but again, that's one of those things where you're going to want to take a screenshot before, at the beginning, during, and at the end of your attestation period. I skipped over, my slides are misnumbered. This says objective 6, but it's really objective 5, and that is health information exchange. Okay, this one is basically the same as the transition of care in the old criteria. So for an EP that transitions their patients to another care setting, or refers their patients to another provider of care, you must use your EMR to create a summary of care record and then transmit that summary of care record electronically. The metric here is 10% of all transitions of care or referrals must be sent electronically. Now, the way that you do that is you use the new direct messaging module within your software. The procedure is that you would create a transfer of care clinical encounter marked as outbound. And that's a good thing to call out here, is that although that printed clinical summary is no longer required, you still need to do a clinical encounter for all patients so that we can track the information. So once you've created your outbound transfer of care clinical encounter, you create an electronic chart summary, and then you would have the referring provider's direct email address, and you would send them that transfer of care summary as a secure email in a direct email message. The transfer of care concept is basically the same, but the direct messaging is new. What's also new, and this is a big one for those of you who are specialists, is that there is now an exclusion for this one. So if you transfer a patient to another setting of care or do less than 100 referrals of care during your 90-day attestation period, you can take an exclusion for this one. If you're scheduled to be in stage 1 in 2015, you can take an exclusion to this measure altogether. A couple thoughts about direct messaging. The direct messaging service is handled by SureScripts, same people that do the electronic prescribing. Once we request your direct messaging module, you will get a phone call from SureScripts in order for them to do a voice verification of your identity. Since you'll be transmitting protected health information via email, it's extremely important that they positively identify the point of contact in your practice who will be doing this. In order to do this, SureScripts utilizes a service that's provided to them by various credit reporting agencies. And the way it works is SureScripts will call the point of contact in the practice and ask them a series of questions based on that person's personal credit record. We've had some phone calls from some practices where they've been a little concerned that SureScripts is on the phone asking them questions about their credit history. I'm told by SureScripts that they do not have access to your credit rating, nor are they checking your credit. They are simply using your recent credit history to positively identify the person. And I'm told that they ask questions like what is the color, make, and model of the car that you're financing through GMAC, or they'll say, I see you just bought a refrigerator at Best Buy, tell me the make and the model, or something like that. So they have access to that information, and they're going to use that information to positively identify you. So don't be concerned when you get that phone call. SureScripts also maintains a database of all providers in your area, and they have their direct email messages, or excuse me, their direct email addresses. So if you don't have them yourself, you can get them, the referring provider's email address from them, and then send them the direct mail message. Okay, so this says Objective 6. This is Objective 6. The last one was a mistake. The numbering was a mistake. But this one is this one is patient-specific education. You need to use your EMR to provide patient-specific education to 10% of all the unique patients that you see. If you're in stage 1 this year, you can take an exclusion to this one. Okay, our next objective is medication reconciliation. Nothing too different here from the prior set of rules. So for more than 50% of transitions of care, or for those patients for whom you think it's appropriate, you need to do a medication reconciliation. Stage 1 providers can take an exclusion. Objective 8 is patient electronic access. I think it's safe to say this is the one that most people were hoping for or were anticipating a change. This is WebView, or the patient portal. There are 2 measures here that need to be satisfied to meet this objective. The first one is that for 50% of all of your unique patients seen during your attestation period, you must provide them the ability to access their information in a timely fashion. So that that's exactly what it was last year. You just need to give them access to WebView. The second measure here to meet this objective, and this is the big change, is that during your reporting period, at least one patient must log into WebView and download or transmit their health information. This is the big change. If you recall at the outset of this year, it was 5% of all the patients you saw had to have used this. Now it's down to one patient, not 1%, but one patient. And if you are in stage 1 this year, you can take an exclusion altogether on this one. Okay, objective 9 is secure messaging. There's only one measure here, and that is that you must provide your patients with the capability to send and receive a secure electronic message. No percentage here, it's just yes or no. Secure messaging is a function of your WebView patient portal. Again, you just have to provide them with the capability to do it. And for those of you who are in stage 1, you may take an exclusion to this one as well. Okay, the last objective, number 10, is the Public Health Reporting Initiative. There are actually 3 measures here that are required to meet this objective. The first one is that you have a connection to your state's immunization registry. You can take an exclusion to this one if you do not administer any immunizations for which your state does not collect data. For most states, any immunization is counted, including flu shots. You can take an exclusion to this one if your state does not have the capability to accept data from your EHR. But as far as I know, all states, or at least most states, do have the capability to do this at this time. There is a second measure that you need to satisfy to meet this objective. Let me go back one slide. Okay, the second measure is that you report syndromic surveillance data to a public health agency or to the state health department. You may take an exclusion for this one if you are in a category of providers for which syndromic surveillance data is not collected by your state, or if the state agency is not able to receive it electronically, or if they have declared that they are not ready to start receiving electronically. You should check with your state's Meaningful Use Resource website to find out if they can accept syndromic surveillance data. Many states cannot. As far as I know, Maryland does not, but I believe that Virginia does. So please check with your state's registry, or their Meaningful Use help desk website to find out if they accept syndromic surveillance data. The third measure that needs to be satisfied for this objective is the use of a specialized registry reporting. At this point, I do not believe that the McKesson EHRs have the capacity to submit data to specialized registry. Given that this final rule is just a week old, we've not yet got any direction from McKesson, but I believe that this refers to cancer registries, and in the prior set of objectives we could not submit to cancer registries. So I believe I am correct in saying that you can take an exclusion for this one, but I will double check. So those are the new 10 objectives. There's that third one. Those are the new 10 objectives. One of the things that I do want to talk about before we go here is that at some point McKesson will update their performance metrics reporting software to reflect the changes, but I don't know when that will be. So in the meantime, what I'm showing you here, is a list of, on the left, the 10 new objectives, and on the right, how they cross-reference to the old objectives. So until McKesson updates their performance metrics report and gives us the ability, or gives you the ability to run your reports based on these new objectives, you can use this cross-reference to run the current reports and see how you're doing against the new objectives. Okay, so those are the new 10 objectives. However, there are a few things that haven't changed. You will still need to report on a total of 9 clinical quality measures that cover at least 3 of the National Quality Strategy domains. Of those, NQF 0018 is strongly encouraged, since controlling high blood pressure is a high priority goal in many national health initiatives. Lastly, I want to touch on PQRS, or the Physician's Quality Reporting System. It's not technically part of meaningful use, and you can successfully attest for meaningful use without meeting PQRS. However, you should participate in and report on PQRS measures. 2015 is the basis year for a payment adjustment that will take place in 2017. There is anywhere from a -2% to a +4% adjustment in calendar year 2017, depending on how well you do with the PQRS program this year in 2015. While PQRS is not part of meaningful use, the PQRS data can be extracted from your CQM data to meet the objectives of this program. We will cover PQRS in a future webinar. So that's it. Before I leave you, I do want to let you know some additional resources. We will be posting new and updated information to the AVS Medical blog page that can be found at our website. Across the top right hand corner there's an option that says blog. I encourage you all to go there right now, select that and click register. Just put your email address in and you'll be automatically registered. That way you'll get information as soon as it is released. It'll be delivered to you automatically. You can also go to the CMS EMR Meaningful Use homepage and you see a clickable link here. There is also a beginner's guide to PQRS from CMS, and there's their link. And then last but not least, if you prefer not to do this on your own and have AVS Medical help you, we do offer both meaningful use and PQRS consulting services. Please give us a call. We would be happy to work with you. Thanks very much for your time this afternoon.